Welcome to the Voyage Clinics podcast. I'm Dr. John Sanders, family physician. Our mission and objective with the Voyage Clinics podcast is just to bring education and knowledge about health and wellness to the community. Joining me today is my guest, Dr. Lee Trotter. Friend of mine, we have lunch together sometimes at the hospital and talk a lot, and today we happen to be wearing matching scrubs. That's funny. Dr. Trotter is a board-certified general surgeon, specializing also in pediatric surgery and bariatric surgery. Graduated from Western University Health Sciences with a residency internship at Kessler U.S. Air Force Base Medical Center. Where's that at?
That's located in Biloxi, Mississippi.
Let's go.
It's the largest Air Force base in the country.
Okay.
So it's a large teaching base and hospital there.
Is that what inspired your passion for flying and for airplanes and stuff?
No, that predate. In fact, I know it's a little bit off topic, but I couldn't decide if I wanted to be a doctor or a pilot. So ultimately, I just did both. So anyway, I'd like to say the physician side of me allowed me to finance my other passion. But that's all I do now. I doctor and fly.
Yeah.
That's it.
Do you use your airplane to fly to different locations
I
to
do.
doctor?
I do a lot of consulting, and so I do go from here to there. If I can stay out of the airports, the commercial big airports and TSA, I'm a lot happier.
That's funny.
But yeah.
What got you into the flying piece?
You know what? I flew airplanes as far as I can back as remember, little toy ones. I'd fly around in the space and 100% perfect landings, on my desk and stuff. And then it turned into radio controlled planes, and then ultimately sitting in a real plane, and it's
cool.
a lot of fun.
That's really cool.
So much fun.
Huh.
So
do you just small prop, big prop? What do you?
Well,
do?
I've owned a variety of planes, and each plane has a different mission. But and my family was large. I had 5 children and my wife, so that's 7 of us. I needed a big twin to fit everybody, and then I've kind of downsized when the kids moved out. And so I currently have a plane called a Mooney. It's a single engine, 4-passenger, but it's a pretty quick little airplane to get me from location to location. And then I've got we call a bush plane. It's a Cub, a high wing with great big cartoon looking tires on it that allows me to land in the middle of a field or up in the mountains typically, and we camp and just kind of hang out. So yeah, it's a lot of fun. It really kind of makes the world a smaller place.
Totally.
So,
wow.
We enjoy it.
I want to hear a ton of those stories.
Oh,
We're going to bring you back.
And we can talk
about
just
flying.
airplanes and backcountry flying and, natural hot springs in the middle of nowhere, Idaho.
Yeah.
And I've got some good stories.
Okay, that'd be perfect.
Like.
I've got some places in middle of nowhere, Nevada, where I grew up that would be cool to go check out.
Yeah.
Tell us about your journey in medicine. What was that like? What drew you in that direction?
Well, I started, my father was a chiropractor, and so I kind of was raised a little bit with the health idea. My mother was a nurse, and I ended up, I don't know, I think most physicians, and you may have had the same experience, I don't know that I chose medicine. I think it chose me. And from, like saying, I was either going to be a pilot or a doctor, but obviously the doctor won out. And I didn't know that I was going to do anything else. So through my undergrad and everything, I literally, if I didn't get into med school, I don't know what I would do, because I don't know how I was good at anything else or had the passion for anything else. And so it was just kind of a natural flow. I just went from undergrad to med school, and you kind of, at least for those who've been this journey, you'll know what I'm talking about. If I could just get into medical school, home free, I'm done. I got it. Life is set. And then you get into med school and find out, oops, now I've got an internship and residency. If I can just get the residency I want, life is set.
Yeah.
And then you kind of get through that, and then you find out, oh, now if I can just get a job somewhere, and you're always looking for that next thing. And that was almost 40 years ago, and I'm still trying to figure out what I want to be when I grow up.
That's amazing.
So, but that's kind of what got me there, and it's fun. you know, as far as general surgery, why that versus say family practice or anything else, I don't know why. I was always going to be a surgeon. I always liked to fix things, and instead of managing problems, I just like to fix them.
Yeah.
You know, and I appreciate my colleagues that are in the primary care arena, because they do what I probably couldn't.
But sometimes I need a fixer, and I'll call and say, hey, I need you to fix this hernia.
Yeah, and I'm really good at that. I'm really good at fixing it. And so it was kind of that. I've been in medical education for my entire tenure in medicine, and I often will have medical students come and they'll rotate with us and say to me, "Do you think I should be a surgeon?" And I straight up just say no. And they look at me like, am I going to get a bad grade? Did I not do well? And I said, no, it has nothing to do with that. I said, if you have to ask me, the answer is no, because it's a calling. You hear it, and it shouldn't matter what I say. If you want to be a surgeon, you're going to do what it takes. And the outside influence is irrelevant. And you just do it. And that's kind of how that's how it was for me anyway.
Just pursued it with singularity of mind.
There
was
nothing else. And it was a tough road. You know,
surgery's a tough road.
It's a tough road. And not just the training. I mean, I know now we've got, 80-hour work week restrictions that are kind of loosely adhered to, perhaps. But
I signed off on all mine.
Yeah. Well, back in my day, there was no such thing. And we clocked in, I was military, so they kept track of that. We clocked in at 120 hours per week out of the 144 that exist.
I think I was on the tail end of some of that. I mean, we still had to sign the paper, but we always worked more than that. But we had to sign the paper that we only worked 80 hours that week and all that, and attest to that.
No, I know that's what I'm saying. But it's tough. The road was tough for everybody. But we're called residents for a reason. And you live in the hospital, and I'd go home every third day. And they'd say, change your underwear and come back, and that's about all you got the time you got to do.
That's right.
And so it's. But it was fun, it was a journey. It's not something that I look back.
4 years of med school, 5 years gen surg residence, and then did you do other stuff?
I didn't do any, at that point, I didn't do any official fellowship. A lot has changed. So for instance, laparoscopic surgery, which we'll probably get into a little bit later on, some of the general surgery things that are newer. That didn't exist when I was a resident. Wow. And it was my generation that basically developed the tools, the adapting the open procedures to the laparoscopic approach, or the mini incision approach, where we use a camera to see everything instead of a big incision. And so I was very much involved in that process. Ethicon, which is a Johnson & Johnson company that manufactures a large portion of the tools we use for laparoscopic surgery, I was hired by them to help develop a lot of those tools. Wow. So I spent a lot of time in the lab, trying to figure out the chopsticks, if you will, to go in and do the different things that we do. And so now you can take a whole fellowship, additional training in just laparoscopic surgery.
Right.
Which again, it was kind of odd. I'm teaching the fellows, and they're getting a certificate that says I did all this, and I still never had one. I couldn't even get one. I thought I'd make up my own and put it on the wall and sign it, because I'd signed so many others. Why not sign my own? But it didn't mean anything to me at that point. And after a while, I don't have anything to prove.
That's so funny.
But anyway.
Well, Lee, that's so cool. And it's fun to hear your journey, and wow, what depth and breadth that you've come through, that kind of this pioneering of some of these major changes in that industry, in your subspecialty. I'd like to just talk a little bit about that space, surgery. The general public. What are the gen surge procedures that you do a lot, and then can we talk to some of those and maybe some changes that have been newer advancements in those spaces?
Sure. Yeah, general surgery is a very broad category that includes just about everywhere on the body. I think if you eliminated brain and spine surgery and then orthopedics, broken bones and such like that, if you took those things out, what you have left is going to probably fall into general surgery in some manner. Now, we do have specialists, especially today, over the years and over the decades, we've become more and more specialized. And the true general surgeon that's my vintage, we don't see a lot of today. You're going to have to get someone that's a little older. Most of us have specialized in colon surgery or cancer surgery or chest surgery. And then there's always been disciplines like gynecology, urology that, are very unique niche areas. Mm-hmm. But the general surgeon is going to be your trauma surgeon. He's going to be or he or she is going to be the person that if you're in a car accident, that's who you're going to see that has some training in trauma.
Yep.
If you have a gallbladder problem, appendix, ulcer disease that medicine isn't working anymore, heartburn surgery, all of those elements are going to fall under the purview of a general surgeon.
Some of my favorite stories from med school and from my training were in my trauma surgery rotation in Hollywood, Florida, which is between Fort Lauderdale and Miami. And it was amazing. All kinds of gunshot wounds. We were cracking chests. We were doing some top shelf trauma down there.
Oh yeah, and it's a busy place. I actually a large portion of my trauma was done in Miami at Jackson Memorial.
Oh, I know Jackson,
which is we called the Knife and Gun Club. But the stories are endless. There's a reason why there's a lot of these TV shows, the series, that are hospital based, because crazy stuff happens.
Yeah,
that the public is like.
Amazing.
You think it's TV, but I'm telling you, most of it's based in reality.
Oh, yeah.
It's like, that happened.
Yeah. So anyway, we got stories for days. I'd love to go back and forth with some of those. But let's talk about gallbladder.
Okay.
Really, really common. I see it more and more now. I think we're getting largely in the metabolic syndrome. Dr. Falahati and I, he's an endocrinologist. We did a whole podcast on the obesity epidemic of America, the metabolic syndrome phenomenon, and how our carbohydrate infatuation and sugars and everything and fructose, sucrose and everything is really creating so much obesity and gallstones and all this extra triglycerides and things that are forming these gallstones. I'd love to hear from your perspective. Anything new, anything changed, and then what can we do to prevent it? And then what's your management when do we think, oh, I've got a gallstone, like biliary colic, like those signs and symptoms, and and so that's pretty broad and rapid fire, but you could just take it and go with it.
We could do a whole podcast just gallbladder biliary disease. But let's start out really quick with the basics. The gallbladder is going to be located in your right upper quadrant, just underneath the rib cage. The gallbladder is about the size of your fist, and the gallbladder is basically a bag that stores bile, and bile is made, of course, by the liver 24 hours a day. And once it's made, it goes into the gallbladder where it's stored for a period of time, usually between meals, so that when you eat, your stomach sends a message to the gallbladder that says, hey, we got food coming down the pipe here, and the gallbladder will then push the bile out. That goes through the bile duct system, and it drains into the duodenum, which is the first part of the small intestine where the stomach is emptying. And it mixes with the fats in our diet and helps us absorb those fats. And that's its function. Of course, we're built to have a gallbladder so that the bile comes in tidal waves, so it squeezes and the intestine will see a tidal wave of bile, and that's the normal process. When we lose a gallbladder, and we'll fill in the gap here in between in a minute.
Yeah.
When we lose the gallbladder, your system works almost identical to the way it always did. The liver still makes bile, but instead of the bile hanging out for a few hours in between meals within the gallbladder itself, it just drips out into the small bowel. So instead of the tidal wave effect every so often, you get the leaky faucet, drip, drip, drip. Most people, and I can use rough numbers here, about 90% of people, I could take their gallbladder out, not tell them what I did, and they'd never know. I eat whatever I want. I don't know what they did. I'm better, and life goes on. About 10% of those people will find unique food intolerances. And it's usually one or two things. And I've heard everything from popcorn to asparagus. And I don't know who those 10% of people are. And it's not because, my mom had her gallbladder out and had problems, therefore I'm going to. And that's not the case. It's a very individual experience. And they might say, before I used to be able to eat, and I'm making something up here, broccoli. And I would do fine with it. They took my gallbladder out. Now I eat broccoli and I get a little crampy and some diarrhea afterwards. I don't eat broccoli anymore. But everything else is fine. So it'll be something kind of unique like that. And it's going to be somewhere in the 10% range. But
that's really good. I can tell you're in education. You did a wonderful job of breaking that down for me. That's super cool. I think that we did a whole podcast on nocebo and placebo.
Yes.
And if people learning this is really valuable to me, but also valuable for all of us as a community, because then we don't nocebo ourselves. I'm getting my gallbladder out. I'm going to have this syndrome that happens when I eat a bowl of ice cream, right?
Right.
And so to know that it's 10%, most people actually have zero symptoms. That's really cool to me. That's really neat.
Yeah, and again, this doesn't equate to lactose intolerance, or I can't do dairy anymore, or any of these things. A lot of people come to me and say, I can't eat fat anymore after I have my gallbladder out, and that's actually not true. And it's the opposite. In our diet, we still need healthy fats to be healthy.
Yeah.
And so we still need to have that in our diet.
Yeah, I was always of a mind that it was fats that you eat after gallbladder surgery. You're going to have that dumping syndrome where you get diarrhea like crazy. Yeah. But you're saying it's sometimes asparagus or broccoli or some other things that can be some unique
It's usually not the fatty things.
Really?
Yeah, that's not my experience after nearly 4 decades. It's unique foods, and I can't. I'd be amiss to say, this food group is going to be a problem.
Yeah.
It's not that way.
Okay.
It's
that's good. That's good feedback.
I tell them, just go do your thing. Now, of course, I always promote healthy eating, and you just brought up, the sugars are the killers for most people, literally. And so I said, just go eat your thing, eat healthy, be responsible, and see where things fall. Now, in the first week or month, I picked on broccoli, so I'll just still pick on broccoli. But if you find out the broccoli, just didn't agree with you, I said, just put it on the back burner, wait a couple months, let your body get used to the new plumbing, and then try broccoli again at month 3 or so. If it still gives you grief, it's on the list.
Yeah.
It's a done deal.
Yeah.
Now, it doesn't mean you can't have broccoli. It's just you'll pay a little penalty. If you really like broccoli, you're going to have a little penalty there.
Love it.
But it's not bad.
It's kind of a scientific approach to it instead of just
it's
broccoli. I'm done with the broccoli.
Yeah, so I just wait, and because I do have people that will say, this bothered me or that bothered me, and then they come back and I see them or whatever. How are you doing? Oh, fine. Oh yeah, by the way, my broccoli that doesn't bother me anymore.
Yeah.
So, but that's cool. So let me back up. So we talked about the front end.
Yeah.
Okay, what gallbladders are. We talked the back end about we take them out and what happens. If you mind, let's kind of hit the middle part. Can we what do we do to stay out of the operating room?
Yeah, healthy gallbladder.
Healthy gallbladder.
Yeah.
So when you look at the numbers, and these are all rough numbers, but they're easy to remember, about 20% of people in our country, in the U.S., will get gallstones across the board. It's just the way it is. Why did they get it? There's a variety of reasons. There's a hereditary component that I believe is there. And then there's a dietary component, which leads to obesity, which is the real link. Isn't so much this food or that food, eating high cholesterol foods or high fat foods or whatever. It's usually not that. It's the foods that cause obesity. Obesity is the strongest link that you can change. The other links that are for gallstone and biliary disease, you probably can't change a lot of it. Genetics, you're not going to change that.
Yeah.
Female is a risk factor.
Yeah.
You're not going to change that. Despite some people trying, your body doesn't recognize that. Your age, so it's typically middle-aged folks, and you're not changing that. So then you're left with your weight.
Yep.
And so those are the components.
We learned a kind of a derogatory acronym.
I was trying to
the triple Fs.
Yeah, I was going to stay away from that, but you can bring it up.
I'm going to bring it up. It's something that they teach us in med school.
Yeah.
It's just fat, fertile females.
Yes.
And so that's the risk factors.
Those are the big. Those are them,
gallstones.
and that's what I'm saying. And two of those you can't change.
Yeah.
To being female in middle-aged or 40s.
Yeah.
And then you've got the weight. You can change the weight.
So just eat healthy,
There you
stay
go.
lean.
Yeah.
And the eat healthy, stay lean thing is like nutrition science is so interesting, and how it's swinging all the way around circles, and how we were like, oh, this is the way we should eat. And now we're like, well, this is maybe not the way we should eat.
I'm because I do a lot of obesity treatment and surgery and stuff like that. I've got a passion for this, but there's so much, if you look at the food pyramid, the pyramid's been right side up, upside down, I don't even know what it means anymore, but I try to really keep it simple. And when it gets to healthy living, I just say, you can call it the caveman diet, whatever you want to do it. But if you could eat it, if you were a caveman and you could find it and eat it, it's probably okay. Mm-hmm. Which is going to eliminate all your processed foods. It's going to eliminate all of the chemicals. It's going to, eliminate high sugar loads because they didn't exist back in those days. But it's going to add, instead of looking at everything from a negative standpoint, I like to look at things from a positive standpoint. I think people respond more to positivity than you can't.
Yep.
I like you can. So we can eat Mother Nature stuff. And if Mother Nature provides it in her storehouse, I think you're probably on a good path. So when you go to the grocery store, if you haven't mentioned this before, you pass the bakery, and anything along the perimeter of the store is probably fair game. Yep. There's nothing in the aisles you need unless it's a paper plate. But outside of that, and so that's just some very generic, easy to apply principles in your eating.
I love it. And by doing that, we're avoiding gallstones. We're avoiding.
We are. Well, you're avoiding
the part that we can.
Yeah, that's the part you can change because it's addressing the obesity link. Mm-hmm. Again, the genetic link in your predisposition to forming gallstones, whether they're cholesterol stones or bilirubin stones, which are the two most common stones, those are going to be genetically based elements that you can't do anything about that. But the obesity link is strong. It's a strong link.
Does the familial hypertriglyceridemias, does that contribute? Or
it does.
Familial hypercholesterolemias?
Well, you've got your spleen diseases, spherocytosis, things like that.
That'll be the bilirubin ones.
That's gonna put you toward the bilirubin.
That makes sense.
These are the genetically based elements, and you can try to bring your cholesterol levels down and triglycerides down. That's another topic in and of itself, but. you're going to have bang for your buck. You don't want gallbladder problems. Stay lean and mean and healthy and eat. And you do that by eating healthy foods, by being active, not snacking and grazing all day long, staying away from the high caloric type of things like alcohol and the soft drinks, these things that they're just not healthy for us. They caveman didn't have them.
No.
They're made up, and there's a price to pay for everything.
Processed food and sugar are like the downfall of the American dream. Like if you look at our obesity levels and what's happened over the last 20 years, we've put more fructose, sucrose into our foods, more processed, high processed stuff. And it's a shame. It's just really killing our population, our community. Unhealthy, very difficult.
Some interesting deals. This isn't an adult problem. This starts back as children, and obese children become obese adults. Now, this is an interesting fact that you can take a mother who's obese is more likely to have an obese child. That same mother who bears a child who's now slender, that child is more likely to be slender.
Oh, interesting.
Yeah, so there is a link. It goes clear back to in utero. So there's a lot of science that we don't know, but there are these links that we can't explain, but they're true.
I think some of that is epigenetics, right? So what turns on genetics is like 3D printers for our body, and so what turns on this person's 3D printers to do these 6 or 7 obesity genes as opposed to that person not? And interesting, I didn't think about it actually happening in utero. We talked about it like happening post utero and how certain things turn on those obesity genes in us, like artificial sweeteners, things like that turn on those genes that do things that create more obesity in our population.
Yeah, I refer to it as a fat switch that's on and off.
Yeah,
and insulin, for instance, when you get high insulin levels, is flipping the obesity. Let's make fat switch turns on,
and that obesity and that insulin switch is turned on by processed foods and sugars, right? Like
correct.
Massive.
Yeah.
Well, very good. I think we've got a good understanding of the gallbladder.
That's
now.
gallbladder.
When it bugs us, typically, what I've seen clinically is like a right upper quadrant under the rib pain, usually worse after eating, and it's going to bark at you profoundly and then kind of settle down.
Yeah.
And then bark at you every time you eat. So if it's associated with foods, especially fatty foods, maybe biliary colic, maybe get screened for gallstones.
Yeah, if you're getting fats, everything stimulates the gallbladder. Fats stimulate it the most.
Yep.
So the classic is fatty food intolerance, but I've had people that say, I drink a glass of water and it'll set me off. And you're right, you've described it perfect. It's right upper quadrant pains, typically starts 15, 20 minutes after you eat. It can bark at you for a period of 2, 3, 4 hours. Then it'll gradually go away as your stomach is now emptied, and it'll be left with this. You'll be left with a soreness that may be there till tomorrow, and it might not come back for a week, a year. It's roll the dice with each meal. Now, what's happening? You say, why is that? I don't understand that. Well, you've got all these gallstones. It's basically a bag full of marbles. When your gallbladder squeezes, if you have a gallstone that just happens to be in the wrong place, the liquid's getting pushed out. Now that gallstone catches the drift and it plugs the duct or the door. And so now it's like a ball valve. The stone plugs the exit. The gallbladder's still squeezing, trying to get the liquid out, but it can't because your stone's blocking the door, and now you feel that Charlie horse. That's why the pain is coming rhythmically. It might be there a baseline, but it's like, every few seconds, it's like, whoa, that's getting my attention. Then it'll ease off just a bit. Then it'll come back again. And that's what we call the biliary colic. Kind of comes and goes. And so that's one thing. The other thing too, I wish everybody in grade school would learn this. If you have constant pain in your abdomen for more than 6 to 8 hours, that's a doctor problem. That is, go in and see your primary care doc. Go see somebody. You've got a surgical problem, most likely, if it lasts 6 to 8 hours. We could talk about appendicitis, the same thing. When do I go see my doc? I just had symptoms. Well, there's chronic things that, you could do tomorrow or next week. And biliary colic is one of these. If you have 1, 2, or 3 episodes, call your physician and say, I've been having problems. I need to be seen. And they'll probably get an ultrasound, which is the best test for gallstones. And you just lay there and smile, and they rub a little wand on you. It doesn't hurt. It takes just a few minutes, and we can identify gallstones rather quickly. But if the pain comes on and stays on, now you're going from a biliary colic or symptomatic gallstones to an infection state, what we call cholecystitis. And that now, you're now on a time clock. You're going to, by the time a day goes by or whatever, it's getting worse and worse. Then like appendixes can rupture, so can gallbladders. And you just get sicker and sicker, and it's better to just go in and have your gallbladder removed, which is about a 30, maybe 45-minute operation that you go home right afterwards. It's done through those little tiny incisions, and it's very well tolerated. You can be back to work in a day or two if you're highly motivated, and certainly back to full sports and activities within a month.
Cholecystitis is setting in within 6-8 hours after onset. If you've got a 6-8 hour abdominal right upper quadrant pain.
If it's constant for that long. Now remember, biliary colic will kind of come and go, and then it kind of just fades off. So by the time you're into 6 to 8 hours, you say, I'm a little sore, but man, I'm way better than I was. That's colic.
Yep.
If you're into the 6 to 8 hours, it's like, man, this thing is just not letting up. This isn't something that you put on the calendar. Hey, honey, call my doc and make an appointment for next week.
Yeah,
that's unrealistic. This is something to say, I need something done sooner than later. I might actually have to leave work to deal with this.
One of the things that we do, because as you know, like the current healthcare system, it gets harder and harder to get in contact with your doc.
Yes.
It's 17 layers deep. We can't even talk on the phone. I just talked to a patient on the way here. It's easy to get into us at the Voyage Clinics. That's one of our objectives, is just to alleviate a lot of those pain points so that we can be available to hear about those biliary colics and those, cholecystitises and those things that are like, hey, this is a big deal. A lot of people, because they can't have easy access to their docs, they're Googling things. And this, one of our objectives of this podcast is like, let's teach folks some things so that they can say, no, I really do need to talk to my doc. No, I need to talk to them now. And that way they can be just a little bit more assertive with that advocacy space. Yeah. Let's say somebody gets the gallstones, they've got biliary colic. You hear a lot of stuff about we're both osteopaths, we're DOs, we're doctors of osteopathy. It's similar to MDs. We're kind of we do more hands-on stuff, maybe a little more holistic, but there are DOs in every specialty and every subspecialty. Are there reasonable ways to be holistic about the treatment of gallstones safely? So you hear these
I know where you're going with this.
So Dad's Dad's a chiropractor. Some of my colleagues are great chiropractic friends. Some of them are proponents of some of these
cleanses,
gallbladder cleanse, and man, I pooped out a whole bunch of gallstones. And are there? I think the risk of some of those things is they're gonna get a stone stuck in the common bile duct and then create a medical emergency. But are there other medicines? I remember in pregnancy sometimes we use a medicine because surgery in pregnancy is not awesome, and so sometimes we'll use a medicine to kind of dissolve gallstones in pregnancy. Are those reasonable options? Speak to that space a little bit.
Let's address that. I'll cut to the chase, and then we'll go through. And for your listeners who want a little more background, the answer is
just like a surgeon.
The answer cut to the chase. The answer is no. You have gallstones, you need it out. Okay, that's the final conclusion. But let's talk about that a little more. Gallstones is a mechanical issue. So you've got various size stones, some small, some big. The big stones are actually, from my perspective, safer. They can't get out of through the doorway. When they get out of the doorway, you got some serious problems. And I'm going to give you a story because people remember stories.
Yeah,
and
they do.
I want to give you one that's actually personal in my own family. But the big stones can't get out. They're going to hurt you. They could block the duct and you could end up with cholecystitis or the infection, but they don't get out. These are stones. They're rocks. And I mean, they're literally like rocks, and they're made of certain things. There are some medicines like Octagol, things of this that we've used in the past. These are hard on your liver. Remember, everything you take, there's a plus and there's a minus. And the minuses for healthy people who are otherwise healthy, the idea to dissolve a stone with medication is a pipe dream. The risks of the medicine are far worse than the surgery complications. So it favors, the risk-benefit favors surgery. They take a long time to work. And if you do look at people who do take them, the vast majority of them, they don't work at all. And it's something I think us docs are treating ourselves thinking, oh, I'm doing something for the patient, but the literature doesn't support treatment of gallstones with medication. It's just not there. It doesn't work. Back in the old days, we used to make a little cut in the gallbladder, scoop all the stones out, and sew the gallbladder back up and think, oh, that was a good treatment. Well, a year later, that same person ends up with all their stones again. It didn't address the cause of the stone, which we've already talked about. There's something wrong in the gallbladder wall that is messed up. And bile's made up of 3 different ingredients, and when those ingredients get out of sync with each other, you end up with a stone. You precipitate out. That's kind of how it is. I remember as a kid, we'd make Kool-Aid. So we had 3 ingredients. We had the water, we had the flavor packet, and we had the sugar. Now, when I would make mine, I'd put all 3 ingredients, and lo and behold, the next day I'd look in and there's a layer of sugar on the bottom because I put too much of one ingredient. It was all mixed up initially and it looked good, but over time it precipitated back out.
Okay.
And bile's the same way. We've got cholesterol and phospholipids and the bilirubin component that make the 3 ingredients. And then when they get out of kilter with each other, you get gallstones. So the medication, these other, there's lithotripsy where we can blast the stones and disintegrate them into little teeny fragments, and then you pass those. That hasn't worked either because everybody gets their stones back. I've had lots of people try these flushes. Now, again, I'm an osteopath as well. I went with the idea of this more holistic, perhaps non-tradition or less Western medicine approach. And so I'm not opposed to anything that could work. I'm really not. But I've had too many patients try these cleanses and end up in trouble. I've never seen one work. I've never seen one work in nearly 40 years. Now, here's the personal story. My brother-in-law, he's married to my sister, who is as anti-Western medicine as one could be. She does everything that I would say don't. Okay, I love her to death, and she's got a lot of good ideas. This one was not a good idea. So they call me up and say, Lee, I've got, my son-in-law's got, or brother-in-law's got gallstones, and they've been bothering him all the time. We're going to do a cleanse. What do you think? And I said, go get your gallbladder out. They chose to do the cleanse. It didn't take but maybe 2 or 3 months later, with like they're on their 3rd or 4th cycle of cleansing, he passes a gallstone. It gets stuck. He ends up with pancreatitis, which is one of the complications. Ultimately, he goes into liver failure, goes into the hospital, gets his gallbladder out. So he ultimately got his surgery, ended up with an ERCP or a procedure to get the gallstone out. But by then, his liver had completely failed. So he went on the transplant list to get a new liver. where he stayed in the hospital for several months. Now, we believe it was divine intervention, but it was well into his 3rd or 4th month. He was glowing green, and they were doing all they could to try to get the bile out of his blood system, but he was itching. I mean, it's a terrible problem.
Ugh.
Anyway, his liver woke up. Literally, just like woke up, started working, and his bilirubin levels started to go back down. He ultimately ended up with normal liver function studies, some 6 months later. And I thought, wow, this all could have been prevented had we just removed his gallbladder. Yeah. I get it. It's surgery. Nobody wants surgery, but this is a mechanical problem with stones, and stones get out. And when they get out, they cause a whole pile of problems that you don't want anything to do with.
Thank you for that story. That's really scary.
Yeah.
But also, like, just eat right, exercise, stay lean and mean, and hopefully prevent them. If you have a genetic predisposition for them, you may develop them. And what I'm hearing is there's not a strong fix medicine-wise, lithotripsy-wise. It is, you have a genetic predisposition for these. It's a bummer. You're going to have your gallbladder out. About 90% of the time, you'll have no problems. And that's beautiful. So that's a great summary.
Now, and so I guess I never finished my thought. I'm easily distracted. My ADHD or something. I don't know. But anyway, 20% of the population will have stones.
Yeah.
Of the 20, half of them will have symptoms and need their gallbladder out.
Oh.
So that's 10%. So if you have gallstones and you legitly, don't try to make this up, if you have no symptoms whatsoever, you do not need your gallbladder out.
That's good too.
Yeah. So if you, let's say you were, heaven forbid, you were in a car accident and they just ran you through the CAT scanner just because.
Yeah.
And they say, oh, by the way, you have gallstones. You do not need to go find a surgeon and get your gallbladder out.
Yeah.
If you're completely asymptomatic, meaning if you didn't tell me, I never would have known. I've never had any issues that could be from the right upper quadrant pain to indigestion type symptoms to maybe heartburn like symptoms. Anything like that could count as a symptom.
Got it.
But if you have none of those, leave your gallbladder alone.
Yeah.
And half the people with gallstones will never know they had them and will go to their grave with gallstones. No problems. So by and large, that's, again, don't rush to a surgeon just because you have stones. If you have symptoms, if you have one symptom, you're now in the other group.
Yes.
You don't have to wait until you have infection. You don't have to wait till you have 10 episodes of biliary colic. If you have one symptom, sign yourself up, go get it done.
Okay. We have about 10 more minutes left, and this has been really, really good.
There's a lot to talk about.
There are so many people out there, even healthcare professionals, spreading all kinds of information, and some of it is just pure rubbish, and it creates a lot of thinkers out there that are thinking, well, these surgeons just want to make money, they just want to take your gallbladder. And understanding the science, you made one comment where you said the literature doesn't support that. And I think that's really significant for us to understand what that means. What our listeners, when we say something like the literature, we're talking about data, research, and we're talking about time and science, really.
Yeah.
And as physicians, like, we're under oath. We are under oath. It's one of the few professions when they have an oath to do the right thing for people, and we're very careful not to get conflicts of interest, not to create ways that we can sell a supplement in our office and make a bunch of money, or because people trust us, and that's sacred. And that when someone comes to me and they know that they're going to get good data understanding on what science understands about this topic, not what Instagram, TikTok, YouTube are saying, but what science says, I think that's really important for us to know. And I've learned some cool stuff today because I was in the, maybe I just watched too many reels on Instagram, because it's so easy to be influenced in these other ways and to think, oh, well, we should definitely be doing these gallbladder cleanses every couple months or whatever.
Yeah.
And so we could potentially be harming ourselves. And so I just think it's good to just have good information out there for our people. So thank you for enlightening me and hopefully our listeners about more about the gallbladder and about ways to deal with that reasonably effectively. Appendicitis. I've had several. There's pretty big swings in treatment of appendicitis recently.
It is.
Talk to me.
Yeah. Okay. We don't have a lot of time.
Have to be quick and dirty.
Yeah. Just real quick and dirty. Appendicitis is a surgical problem. It's a surgical disease, and that's the end of the story. You have appendicitis, take it out, be done with it. That's it.
Come on.
Okay.
Talk to me.
I know.
Talk to me about the antibiotics thing.
I know. Let's talk about the antibiotics. So antibiotics, we've treated early appendicitis with antibiotics for a long time. That's not something new. Now, through COVID, it took on a whole new life because we literally were not letting people in the hospital for a variety of things. People didn't want to come to the hospital for a variety of things. So a lot changed. And it wasn't just in the U.S. This was actually done more outside of the U.S. where they don't have access to surgery. Surgery may be, like I said, is the best treatment. But what if there's no surgeon and you're out in the jungle?
Yeah.
Now what?
Yeah.
And antibiotics for early appendicitis is effective in roughly about 70-80% of the time up front if it's caught early.
IV, PO, both.
You can, usually they're done IV. Most in the U.S., they're going to come in through the emergency room. They're going to get an IV dose. They might even be admitted, get another IV dose. Things are starting to look a little better, go home on a week's worth of oral antibiotics. Yeah. The downside to this is in the next 5 years, there's a 60% chance you're going to be back and you're going to start the process all over again. The concern I have is that you are going to end up with appendicitis again in the end. When you look at the age distribution of who gets appendicitis, you're going to have really young people, and the next big bump is in the old people. Old people, you start missing cancers. The cause of the appendicitis was a cancer. So the older folks, and when you get, and I say older folks, that's when you're going to hit your 50, 60-year-old. You're going to treat it medically, and you're actually treating a cancer. So those I take out. I wouldn't do medical treatment for the older population. The younger population are going to be your teens. Now these are going to be viral causes in almost all of them. Mm-hmm. In fact, please don't misinterpret that if you're, over 50, your appendicitis is cancer. I'm not saying that. I'm just saying that there's a higher percentage that we don't want to miss that the younger people don't have. So younger people, we're going to do it. We'll treat them medically. They may get over it, but they're coming back in their lifetime. And the problem I have with it is that I don't know where you're going to be. Are you going to be up in the mountains? You're an active person. Are you going to be traveling? Or is it going to be your football playoffs? And it's Murphy's Law. Yeah. I see it way too many times. People are like, I don't have time. I'm at work. There's no way. It's tax season. Or, there's 100 reasons why. So the studies done looking at the medical versus the surgical treatment, a lot of it had to do with economics. What is the cheapest way to take care of this patient? Those studies are all older, where we would do an appendectomy, remove the appendix, and the patient stayed in the hospital for several days, which incurred hospital charges, which were then tabulated on the surgical treatment. And then on the medical treatment, they weren't there. So it looked like, medical treatment is so much cheaper, easier. Okay, so you come back and we do it again. I could do it 2 or 3 times and still be less. Well, those were the older days. Now, when you talk about, what are up and coming and things in general surgery, one of these is the treatment of appendicitis. I'd say 80 to 90% of my patients now with appendicitis, they come into the emergency room. We identify it. Remember, this is the patient. I've had pain for 6 to 8 hours. It hasn't gone away. That's a doctor problem. So they get sent to us. We take them right to the operating room, laparoscopically through 3 little cuts that I dare you to find in a year. These are little, a cut is too strong. They're little scratches, okay? One of them's in the belly button and you can't even find it. So we're making these little scratches. We take the appendix out and you go home. Right from the operating room, you go home. So there are no hospital fees. So now when you do this, if we were to redo those studies for economics, it really is now almost essentially a wash. And if you throw in that most of these people are coming back with recurrent appendicitis, now the medical treatment was more, and it wasn't as effective. Surgery, I can do through 3 little tiny incision things, get it out in literally, and I'm not saying I'm a speed demon or the mark of a good surgeon is speed. It is not.
Yeah.
But a reasonable surgeon on these, it's a 20 to 30 minute procedure.
Yeah.
The doc in and out.
Yeah.
It's hard to beat that.
Yeah.
How do you beat that in an otherwise healthier young person? My children, they don't even know they had surgery. We send them home on Tylenol for pain, and they do wonderful.
Yeah.
I don't use narcotics on kids at all, and they don't need it.
Yeah.
So, I tell parents, I said, if Johnny slows down for a day, count yourself lucky, because it's probably all you're going to get.
Wow.
And so now when you weigh those, and I'm not doing it as I'm a surgeon and I've got plenty of surgery to do. I'm not looking for stuff, trust me.
Right.
If it was my child, they're getting their appendix out because the data, again, yes, you can treat it medically if it's caught early. And early is, I've got some right lower quadrant pain. I might have a slight white count. The ultrasound or CT scan does not show any evidence of perforation or what we call a phlegmon, where there's more involvement of tissue around it that's irritated and infected. If it doesn't have any of those signs, these patients can be treated medically, and I do treat them medically, but it'd be a story like, we've got an important family thing, or there's some element that surgery this minute is suboptimal. Yeah. Is there any other option? And I said, well, yes, there is. We can do this and do medical treatment that's reasonable. Now, if you do medical treatment and the next day it's like, I'm hurting more, you're failing medical treatment. Yeah. Don't think that medical treatment equals success. About 30% of them fail. So you don't want to wait and then perforate. Now you've got even a worse problem. Right. So the next day, if you're not like, yeah, I'm better. I can tell I'm better. You're tickling a tiger, and it will turn and bite your head off. And we just don't want to go there for a 20 to 30 minute case, and you don't have the perforation and all that. I'm going to operate.
And even if we do medically manage them, 50% of the time, within 5 years, you're going to have it again.
It's coming.
That's the stat you share.
It's a little higher. It's more like 60, 65%.
Okay. So they're going to get it again eventually. They're going to get it again. Most likely.
Yeah. Particularly if a little buzzword, appendicolith, a little stone in the appendix. If that is the cause, and they'll be able to tell that on their scan. So if you have the little stone that's the cause of the appendicitis, that's a done deal. In fact, I'll take it one step further. If you were in that car wreck, hopefully not car wreck, and they scanned you just for giggles, and they said, oh, by the way, you have appendicolith, a stone at the base of your appendix. You call your doctor and sign yourself up to get your appendix out. But doc, I've never had a problem. I said, yeah, it's your time bomb. You are getting appendicitis. I just don't know when. So just sign yourself up. Give me 20 minutes. You'll go home right afterwards and you're done.
The lith word is fun. So we get otoliths that cause vertigo. We get phlebolyths.
Yes.
Is it the same as a fecalith? Because
the lith is stone. Is the Latin for stone. Yeah. So
lithotripsy to break up the stone.
Yep. Lithotripsy, cholelithiasis for gallstones.
Yeah.
It's all stones.
Is a fecalith the same as an appendilith? I mean, it's in the same vicinity. I've gotten a lot of KUBs to check for like galls.
A fecalith is going to be a stone in stool. It's going to get pooped out. So that I don't care about. Appendicolith is in the base of the appendix. And what it is it's just stool that's been dehydrated over and over and over until pretty soon it turns itself into a stone. And they're soft stones. When I take them out, I can actually crush it in my finger, but it's nonetheless a stone.
That's kind of gross, but
cool. It is. It's kind of gross, but you know, those are probably something that, you know, not the common person's going to know about, but they're real, and they happen a double-digit % of the time as a cause.
Lee, we have covered some beautiful stuff today and some less beautiful stuff, but thank you so much. I think, you know, the two most common gen surgery procedures, gallbladder and appendicitis. Wonderful. I'd like to bring you back. I'd like to talk about colon cancer. I'd like to talk about some trauma.
Yes.
I'd love to hear more about some pediatric surgeries that you do, and then maybe even some bariatric weight loss stuff and where your knowledge is there too. So we might have maybe 2 more podcasts in us together.
I'd be happy to do it. Before we go, and this is trauma season, let me just in sake of time and hopefully prevent some poor child, the 2 big things that are disturbing to me that we see too frequent that are devastating injuries for kids. One is button batteries, those little tiny round batteries that we use for watches, for a lot of different things around the home. The little cards, the get well cards have a little button that talk to you, have a button battery. Get them out of the reach of your children. If they swallow them, it is literally a life-threatening thing within hours. And you don't typically know. They think they're little candies. They eat them. They get stuck in the esophagus, and they literally burn a hole right through. And where it's at is all the main blood vessels in your body, and it burns a hole straight in, and it's over. It's done. If they happen to swallow one, they go straight to a hospital. And if you want to give them a tablespoon of honey on the route, that would be preferred. But that's the one thing. We see a lot of it. I'm probably monthly taking a button battery out of a 6-month-old, a 2-year-old.
Really?
And it's devastating. Okay. The second one is, and this is for all parents, where your children sleep. And this is all ages that, I don't understand it, but move their bed or dresser away from the window. They like to climb. It's hot out. It's usually a 2nd-story bedroom because the rooms are upstairs. It's hot. Window gets opened. I get it. They don't. And they go right through the screen, and they fall 2 stories down. We get one of those a month.
Really?
And it's from their bed, or they crawl up on the dresser. Set up the room so that your children do not have access to the window. They can't get there. And you will be a better parent in doing so.
Thank you for those pearls. It's good to know what you're seeing a lot of and the significance of those things. I can't imagine both those are very traumatic. Thank you again for your time and for scaring the crap out of us at the end there. I appreciate that.
Well, again, it's not all of the stuff we talk about isn't to scare people. I don't like that. I want people to respect the situations that are there. It's not to be afraid of, it's to be educated. And that's why you're watching this. It's a good thing. Yeah. Be educated. Don't be afraid.
Yeah.
Be knowledgeable, and then respect it. And then life is good.
Very good. Let's do this again.
Okay.
To my guests, thank you for tuning in. Don't forget to like and subscribe and do all the things and share it. And thank you. Hope you learned some good stuff today.